people are doing, and it allows us to share our story with our colleagues. So I'm not sure who's going to be presenting.
Dr. Burke's going to present, Director.
Thank you. Was he able to join, Sean, or did we have to put that off to perhaps after? Or, as Amy gave me this mug, you're on mute.
He had said he was going to join. Let me ping him in. He emailed me yesterday saying he would present.
Okay. So what I will do before we have that, I'm just going to go over a couple of talking points because I want to get to the performance measures. So first of all, I want to take an opportunity to recognize staff for the last 2 weeks. As many of you know, we did have a breakout on our CLC. We had a number of patients, we had a number of staff, and people moved quickly. There were a lot of anxious, concerned individuals in this organization, and they didn't have to think twice. They were quick on their feet. 7B and 8B took a lot of this, as did the CLC. So did engineering, infectious disease, and disease physicians and nurses. Phenomenal job. You know, I don't want to name individuals because I may forget someone, but there were people who came in off of their tours to provide education and training, and so many moving parts. It was unbelievable. It was like watching you know, an orchestra, the way in which people moved through the organization. I had an opportunity to go to 7B and talk to the staff, tired, and they are tired, and but they were very thoughtful about and understood the work that they're doing. I didn't get a chance to get to the 8B area, but I will do that. And to thank all of those individuals, just phenomenal. We couldn't do it. Now I know that we're moving back. Our CLC patients are coming back into the CLC. Our staff are coming back. But I think that one of the things, as Dr. Howard would say, that we have to recognize, even though out in the community, you know, things are starting to be people are no longer need to be masked when they go to school as of tomorrow, and a lot of the areas that we're going to, we no longer have to do that as well in terms of masking. But in a healthcare setting, in all healthcare settings, but not just in the VA, masking is still appropriate and needed. So we still have to stand vigilant and ensure that we're doing what we need to do. All right, so the second thing I wanted to say is they are looking at, I did see a message yesterday in terms of lifting the travel ban for people to come together. But however, it cannot be in a healthcare setting. It would have to be someplace else. But I think that's not going into effect till the middle of March. Do want to talk to you a little bit. We had the network meeting last week, and the focus really is on access. And so we are drilling down, looking at access. I have met with Robert Coyle, and I do on a weekly basis to look at our primary care, our mental health, and our specialty care. So all of that, we have specific, and Joe will go over some of those things that we need to do. Understand that we don't have staffing in certain areas, but there are other things that we can do and other things that we can affect. One of the biggest areas is consults with no activity. And so we have a team that's meeting weekly. So we are focusing in on all of these things as an organization. That is our job, and that is what we'll do. And we're here to support everyone. The second thing that the network director wanted us to know is what they're doing at a national level. They're also looking at our expansion. And that's hard to look at when people want to take a deep breath and say, I'm tired. I know that. But now we need to continue to work, continue to open up, because at the end of the day, it is all about the veteran. And they need the services, and we need to provide the work. So are we ready for the safety story, Sean?
Director Dr. Burke must have got tied up, but I have a safety story on standby for just such events. So
Well, why don't we hold it for right now? And
Okay.
I would like to introduce Mr. Cohen, because I don't want to take much away, and a lot of the safety stories are in his presentation. So Joe Cohen is the health system specialist, the director of strategy and development at the network level. Joe is not a stranger to any of us, and he definitely is not a stranger to me. I'm in awe of Joe's ability and his way in which he teaches us. So Joe, I'm going to turn it over to you. So that you can go over our do you have slides? Does someone have your slides, Joe?
Yes, good morning, Darlene, and thank you. I do have slides as well as perhaps some other attachments that I'll share with the group. So I'll get started if that's okay.
Perfect, Joe. Perfect, Joe.
Okay, can everyone see the first slide?
Yes.
Yes.
Excellent. Thank you, and good morning, everyone, and thank you for the kind invitation to speak with you today. What I'd like to do this morning is discuss the current performance measures and requirements, and we'll look at the NDPP plan, look at sale results, as well as a newer feature that the Assistant Undersecretary's office is using to monitor many of the sale measures, especially since they discontinued the star ratings. So in order to fill that vacuum, there are other features that they're using to monitor sale. And we'll also look at the revised performance reports and dashboards to help us navigate some of these different requirements. We'll highlight the first quarter of FY22 results, look at some trends and challenges, and then discuss recommendations and strategies. And then I'll leave time for questions and discussion, and invite any input that you might have. For the sale clinical composites for fiscal year 2022, they did make certain changes, especially to the outpatient composites. We have the behavioral health screening and tobacco use and cessation screening composites. Those are basically unchanged, and we'll look at some of those results. There is a new cardiovascular diabetes composite, which is a combination of what we previously had for ischemic heart disease and diabetes. They've essentially combined them. And we also have a prevention and women's health composite. They have made a change to the cervical cancer screen, so it is a new composite that we'll look at. And then two additional ones that we had not seen before: the percent of all tests that are compliant with VHA directives, and then for infection control purposes, the sepsis early management bundle. The inpatient global composite is basically unchanged. Three of them are uniquely in the NDPP. There was a movement to place greater emphasis because of COVID and the lack of face-to-face across the VA system. The behavioral health screens, as well as cardiovascular and prevention screens, did go down on a national level, and so they wanted to underscore the importance of these things, especially as we're transitioning to more face-to-face meetings. The revised performance dashboards and reports, I just wanted to mention a few things. I'm trying to modify these reports so that we have a better opportunity to monitor all of these changes. So I did build into the dashboard comparisons to prior results, prior years. We'll look at that. Also, I'm comparing all of our performance results to the top 10th and 25th nationally. So for every measure, I've analyzed the 140 VA facilities across the country and then the 18 VISNs. And so it's color coded so that we can see immediately how well we're doing. So it's essentially a dual measurement gauge of both absolute improvement in the scores and then relative performance assessment. We also incorporate for the first time the new clinical composites with the individual measures for each composite, and that's a new feature which we'll look at shortly. We also built in the targets for the NDPP measures, and because they're placing much more importance on readmission rates. In fact, we had a meeting with Dr. Dill and a lot of physician groups just on Friday. Readmissions are now being broken out by cardiorespiratory, cardiovascular, medicine, neurology, and surgical. So we do have some additional reports which we'll look at for sale, some pivot tables and charts to try to help us trend our performance, and then some other statistical reports that I'm going to continue to share throughout the year. Control charts to identify special cause variation, as well as correlations to identify statistically significant relationships among hundreds of variables that we look at. For the behavioral health screening, I included Albany against the national and VISN-2, but we can drill down to any facility. And in the case of Albany, you do see a major improvement in the behavioral health composite for the first quarter of 2022. So that's excellent. You can see Albany is above national and VISN-2 at 94.89. Last fiscal year, concluding with the fourth quarter, the 92.31 is where Albany was. So that's a major improvement. And I am showing where COVID was. Interesting pattern. The whole system did start to drop. The one thing we were concerned with as a VISN is VISN-2's drop actually started before COVID, and that's also true of Albany. So we do want to be very focused on that. COVID is not responsible for all of the drops in performance measures, yet it is used quite freely to explain some of those decreases. This is a component measure within the behavioral health composite, PTSD screening. This has been a concern of ours, and you can see for Albany, the 95.2 for the first quarter is considerably less than where we were in the past couple of years. And for the VISN, that's also the case, but Albany's is lower, so we would like to focus on that. It's considerably lower than both the national and VISN-2, and we'll look at those within the dashboard shortly. So this is the behavioral health screening composite that I include in the dashboard. It does compare our performance across the VA system, and you can see the VISN at 94.1 does demonstrate an improvement over last year, but it's still in the bottom 25th percentile. Albany does a little bit better, as we showed, but still is worse than the VHA median. So we'll continue to monitor that throughout the year. And then when we look at the composite measures that make up the behavioral health screening, you have a number of measures of annual screening for depression, PTSD, alcohol misuse, and so forth. And you can see Albany does better for the screening for depression, as well as veterans screened annually for alcohol misuse, somewhat below for the other three measures. So we'll be looking at that to improve for all of our facilities, including Albany. And this is the tobacco use composite pivot chart. Also for Albany, you can see a reduction through the first quarter of 2022 at 93.3. National is at about 94.7. But there are facilities and VISNs across the country that are at the 98, 99 percentile, and we'd like to look at that and perhaps benchmark with them, because COVID does not seem to have affected their nearly universal screening for tobacco. And if we look at one of the measures within tobacco screening for use, you can see VISN 2 is below at a 89.94, Albany just below that at 89.3. And you can see the pattern where that reduction actually started taking place for our VISN before COVID. And these are the component measures. You can see where a VISN 2 is. We are unfortunately in the bottom 10th percentile as a VISN. Albany does a little bit better in the bottom 25th percentile, but we'd like to see that improve. And again, for all of the component measures, Albany's at 100% for 3 of the tobacco use cessation metrics. And it's the Nexus P7, or screening for use for tobacco, that is most problematic for Albany and the VISN. And that one is heavily weighted, so it's very important that we improve there. These are the behavioral health screens across the country, and I wanted to show how well some of the facilities have done across the country. I then interspersed our performance within there, but the top 10 actually start at 99.4, just to the 99 percentile. So they're doing exceptionally well. Nearly every veteran is getting screened. We start with Western New York for our best at 96.6. But that goes down to 89.3 for New York Harbor, and you can see Albany somewhere in the middle at 94.9. We have the type of staff engagement that certainly lends itself to the 98 and 99% scores. Similarly for tobacco, you can see top 10 facilities nationally are at over that 99 or 98 percentile. Finger Lakes is our best at 94.2 to New Jersey's 89.9, and Albany again is somewhere in the middle of our VISN at 93.3. And I have the national ranks, so these are areas we're going to focus on. In the NDPP plan, for the first time, they did include 3 sale measures with targets, and that's very unusual. Normally, they do not include targets, but again, to underscore the importance of these areas, behavioral health, cardiovascular, and prevention, they have been included. And this is a depiction of all 3 of those that are in that NDPP plan in element 5. And I showed where VISN 2 is. In the case, we're basically every VISN is meeting at least the fully successful, and most are meeting the excellent or outstanding. I did want to intersperse where the sale measures actually lie, and that's a much stricter a set of targets. We do find, while we're exceeding and outstanding for the NDPP, for purposes of sale, and we'll probably be receiving the sale report within a couple of weeks, the quintiles are 4th, 3rd, and then 4th, respectively. For our facilities, only New York Harbor for behavioral health and Finger Lakes for prevention are below the NDPP targets. So Albany does exceptionally well from an NDPP standpoint, but they did set these targets rather low. So we are focused on the sale, because that will also be looked at. For prevention, a very important screen is for retinal exams, and we have started to improve as a VISN somewhat, but it's just recently from 79.2 to 80.8 through the first quarter. Albany, however, did drop to 68.3, so that's something to look at. Foot inspections, similarly, we like to see this improve. As a VISN, we went from 72.2 to 77.8. Albany is down to 68.8 from 82.4. So these are important areas that we want to focus on. If we look at all of the measures, as a VISN, we are just below the VHA median. Albany a little bit below that. But there is a mixed performance among the 6 metrics that we have, and you can see for Albany, the retinal exam would be in the bottom 10th percentile, but the other areas we would also like to focus on. Pneumococcal immunization is the best performing area for Albany, but this is something to focus on, and we'll be monitoring this throughout the year. I'll be issuing the pivot tables shortly with updated results, and we'll also have the second quarter as soon as that comes out. For ischemic heart disease, controlling high blood pressure, this is an area Albany is actually among our leaders. You can see an improvement from 65.7 to 69.3. This is an excellent demonstration of improvement. As a VISN, we still struggle as compared to the national numbers. And for statin therapy for patients with diabetes, you can see a steady improvement. Albany especially is among our leaders at 80.3. So that's an excellent score, well above the national as well as VISN too. So there are many areas Albany's doing very well in, and they're summarized in these reports. You can see for the cardiovascular diabetes, Albany's actually in the top 25th percentile, shown in green. Finger Lakes leads. We have quite a bit of variation across our 9 medical centers, and these are the component measures. So again, this is the first time I've had this in the performance dashboard that way, to try to allow us to drill down to all of the measures. And you can see the statin therapy for Albany, but to your credit, all of the areas from controlling high blood pressure for both ischemic heart and diabetics is above the VHA average, as are the statin therapy for both cohorts of patients. There are 2 additional composites, all tests compliant with VHA directives, and then the infection control sepsis early management bundle. You can see that the problem we're having with that new measure, all tests compliant. Several of our facilities for the first quarter are well below where we'd like to be, but we anticipate that will improve. And Albany's doing well for the sepsis early management bundle. And we'll also look at infections where you're doing quite well. These are composite scores that I put together by CBOC, and these 4 composites that we have, I've got the facility as well as each of our CBOCs, and you can see it is mixed. In some cases, we do better at the facility level, and I'll be sending this out for those that haven't seen it. I've got all of our 62 CBOCs as well as the facilities. And one way to visualize it, if you look at the facility scores and the CBOCs, taking Albany for behavioral health, the scores are about 4.4% higher for CBOCs at Albany than at the facility. For cardiovascular, similarly, the CBOCs do better by about 4.6%, 70.1 versus 74.7. So this gives a level of granularity that we haven't had before. For prevention, the 78.8 at the facility level is actually about 2.5 percentage points above. So that's an example where we do better at the facility than the CBOCs. And for the CBOCs for tobacco, you can see over a 5 percentage point disparity in favor of the CBOCs versus the facility. So this helps as we try to focus on improvement. The sales performance scorecards for the fourth quarter, I will be updating these shortly when they are made available. And just as a VISN, we are ranked 9th from VISN 23 Minneapolis to VISN 2. Yes.
This is Amy. I'm sorry. I don't know if anybody else is getting, but your voice is breaking up and there's a lot of feedback.
Joe, can you
Oh, I'm so sorry.
try and mute everybody real quick. I can't see if someone has no mic, but I'm gonna mute the whole group. Just unmute yourself in like 1 second. Okay, Joe, go ahead. Joe, are you having trouble unmuting yourself?
Okay, can everybody see the slide and can you hear me? I really apologize for the technical problems.
It's still broken up. Do you have a landline, Joe? I can call into your landline.
I do. I don't know. Let me try to move my microphone.
You may even want to try signing out and then logging back in to the call.
Okay. I did move the microphone. Is it still breaking up?
Yes.
I can try to log out, like you said, if that's all right. Again, I'm sorry.
Director, do you want me to read the safety story while Joe's rejoining?
Yeah, that's fine.
Okay. So I have a safety story from January 28th regarding the front office. On January 28th, the front office received a phone call from a veteran who expressed that he was becoming increasingly depressed for the past few weeks and having bad thoughts. Though not suicidal.
So Sean, it's you now that's breaking up, so.
Okay, I'm gonna stop then.
I logged back on. Can you see the slide and can you hear me? If not, I apologize. I'll have to try to reschedule this. Yes. It is better? Okay, thank you. I'm, again, sorry. Let me go through the rest of these. These are the sale aggregate scores for the last report, fourth quarter of 2021. And you can see the Northeast does considerably better Vision 2, as we're concerned about, has underperformed relative to the Northeast, where Visions 1, Vision 23, that's Minneapolis, Boston, Chicago. We'd like to improve our scores and hopefully we'll do that with the first quarter improvements that we're making. These are the sale performance scorecards for our facilities, and Albany, as you can see, at third is the best performing of our tertiary facilities. We are having more problems with many of our referral hospitals. Hudson Valley and Bath are doing well across the country, and this isn't to disparage the complexity level 3 facilities, but I've made these statements having looked at all 140 VAs. It is much easier, although it's difficult for every hospital, but it is easier to score well in sale when it's a complexity level 3 facility, because the size of the acute care component is much smaller. So by definition, you would have fewer deaths, fewer infections, readmissions, and the like. Not to disparage their performance at all, but I do want to put it in perspective. We are struggling, especially with our tertiaries. You can see Albany has actually done fairly well. We'll focus on some areas that we can improve. And this is just another way to depict it for our best performing are Finger Lakes, Albany, and Hudson Valley. We do have multiple gauges of performance results. The NDPP, as I mentioned, has new composites. We have the sale results, where we're focusing on the relative performance as well as absolute scoring changes. And we have a new component that seems to have filled the void of the star ratings being dropped, and that's the EPIC program, or Engagement Protocol for Improvements in Quality. And this is run out of the Assistant Under Secretary's office, where our VISN periodically gets notified based on certain sale performance results. 40% or more of a VAMC's metrics, if they're within the 5th quintile, or 65% within the 4th and 5th, they would be notified, and that would actually be a tier 1 or high support need. Fortunately, none of our facilities are in that category, but there's also the absolute improvement or decline. And what we're showing is that if greater than 50% of a sale metrics have worsened from a year ago, or 50% of supporting indicators have worsened, we are getting notified, and that would be tier 2 or moderate support need. Just looking at Albany, you can see that there's somewhat of an even split between the measures increasing in absolute performance and those decreasing. So it hasn't gotten problematic enough for that notification, but we would like to see more of the measures across our VISN and at each site that actually increase in absolute performance. And there are a number, especially on the upper right for Albany, that we'd like to build upon, although that's very good. For Albany's 3rd versus 4th quarter sales scorecard, we've had 13 that have actually improved, 17 have decreased somewhat, and they're listed. You can see some of the areas that we'd like to focus on. And this also pertains to that EPIC program and the notifications from the Assistant Under Secretary's office. What I have here is the percent of sale measures that are decreasing from 1 year ago, and it's from left to right. Bath had up to 40%, but they've improved to 32%, or about a third. East Orange from 45 to 38, so that's in the right direction. A number of our facilities are starting to creep up in the number or percentage of measures that are decreasing from 1 year ago. Bronx from 26, which was an excellent score. They're now up to 40. Brooklyn's are at about 45. Buffalo has improved from 58 to 45%. They had been notified by the EPIC program. Albany, fortunately, has not been notified, but it's starting to increase from 39% of the measures to 48. You do have to exceed the 50% to trigger that tier 2 notification. And you can see some of the other areas just on the threshold for New York and Syracuse. Both have been notified in the past. Hudson Valley and Northport most recently have been notified as 54%, 58% of measures. This is a fairly new component of SAIL. There are some high performing areas for our visit and for Albany that are declining, and we are concerned about that. And these are some of the reasons we're triggering that SAIL EPIC notification. You can see, I will say where Albany is getting a lot better, just to build upon that strength. The primary care access was down to 54.9, slight decrease to 53.8 last year, still above the median. But the first 2 months have been excellent. Albany is up to 62.1, and that's actually within the top 10% nationally, or the top 14 facilities. The primary care satisfaction with days waited for an urgent appointment, however, has dropped down to 27.3% satisfaction. That's problematic. We'd like to see that improve. And then the specialty care access for Albany from 52 to 47.9 to 45.7. That those are areas we continue to monitor, but we would like to see improvement. And then an area we've done quite well in the past, primary care provider ratings. Albany was at 74.2, about no change, no relative or significant change to FY21, 74.3, but there was an improvement on the first 2 months of this fiscal year to 76.1. The specialty care access provider rating, is something that we're concerned with. You can see from 74.8 to 65.5. So those are some of the areas that historically have done well at Albany, but have started to drop. I've mentioned this before, but it's even more important now because we are focusing perhaps too much on underperforming areas, and that and rather than those positive areas that are starting to decline. We'd like to focus on the strengths and make them VHA leading. It's been shown through the research that focusing on underperforming areas exclusively results in a net decrease in overall scores. It's a phenomenon called regression to the mean, and if we focused only on the oranges and reds, there's about a 30% success rate from Six Sigma and Lean. That is in the hospital literature. It doesn't get enough attention in the VHA, in my estimation. So if you focused on 10 areas that were orange and red, the success rate would be no higher than 3 out of the 10 that would improve. If we ignored the high performing areas, they would regress to the mean like gravity bringing down an object. And the net result is a decrease. So we want to focus on strengths every bit as much as the underperforming areas. This is my last slide just for recommendations for sustained performance. We're encouraging a focus on continual improvement or an absolute improvement in the score from 74 to 76, irrespective of the quintile. they are actually notifying us of high performing areas that are dropping, even if they're still in the first and second quintile. And then also focusing on improving relative to other VISNs. That's that duality of both the absolute and relative performance. We are more aggressively managing this EPIC program, or percentage of measures improved, from 1 year ago. Because of COVID, there has been less emphasis on the community comparisons. We'd like to step that up and examine how well we are doing as a VISN and facilities, looking at our community partners or competitors. And one thing I do want to emphasize, top organizations nationally perform critical self-evaluations. They try to avoid the tendency to cherry pick or embellish, and are very critical. Even the 5-star facilities, some of the best teaching facilities across the country, when they were interviewed, they were very hard on themselves, even though they led in so many areas. And when they interviewed the moderate or low performing areas, it was a completely different profile. Leadership they made more excuses. They were not very self-critical. So that doesn't get a lot of attention, but I think it is crucial to improvements, as the literature shows us. And the staff engagement, I want to point out that Albany has done exceptionally well, as you know, and so you have an ideal opportunity to parlay that leading staff engagement. Albany does have the highest AES scores within our VISN and some of the best scores nationally. You really are in an optimum position to convert that level of engagement into ever higher scores. And then as a VISN, we're trying to strive for consistent excellence across our sites. You can see we have an inconsistency. We have a chance to share best practices and benchmark with the VHA leaders nationally, and that's something we'll be encouraging as we share more of that performance. That's all that I have right now. I did have other dashboards, but I don't want to take up the time. I will send all of those out for everyone, so you'll see them shortly. But let me pause at this time, and we can certainly entertain any questions or discussions.
Are there any questions or concerns that you might have, struggles that you might have, or sharing some things that you're doing to make improvements or to leverage your strengths? Joe, the intent here was really so that, as you had said, to leverage our strengths, and we know that we have this ideal effort or ideal opportunity to really impact those areas that we're underperforming by engaging the staff. So this is the part where we wanted to get people to understand that this is just not a paper exercise. This actually is what Albany is looking like. And even though when Joe brought up the slides, we're doing very well as compared to the other level facilities within our VISN. However, you know, we do have to pay attention to the fact that, you know, we're getting closer to that tier 2, where we have greater than 50% as decreasing. So I want our staff, I want the leaders and the people on to understand Why are we focusing on the behavioral health measures? What are we doing for the preventative measures? Have we engaged all staff within the women's health areas so that people understand? Have we shared this information with our CBOCs so that they can see their performance? And that's probably the strategy that we should take, is that we are sharing this information. Joe, I really want to thank you. And I'm going to ask you a question. If others wanted to have you present perhaps to their individual groups, if they had a call to share the information with the CBOCs, is that something you might be able to help with?
By all means, Darlene, I would welcome it. And I agree with your comments earlier. Optimally, we'd all like to meet face to face, and I think there's a greater exchange that way if we could actually see each other at meetings. And I'm hoping to, upon any invitation from you, I'd hope to address the group throughout the year in a face-to-face sense, but I'm certainly willing to do this through MS Teams as well. But by all means, I welcome any invitation.
Okay, so I encourage the service chiefs and the section chiefs that are on this call, if there is an area where you wanted to drill down more and you wanted to ask Mr. Cohen to come and address your team, let's think about doing that sooner than later. I think we have to celebrate, the things that we're doing very well, but the areas that we have to focus on. This isn't about the NDPP. This is about, how Joe has presented it to be an organization which can, hang their hat on the fact that, we are one of the best performers. Albany has been there in the past. Albany can be there. And we will, but that's going to take not just me sharing the data, that's going to take all of us rolling our sleeves up and doing what we need to do. So are there any discussions or questions from Mr. Cohen, for Mr. Cohen?
I have a question, Director.
Thank you, sir.
Chris Ashley for Medicine. To what degree has there been an effort to drill down on the particular measures and identify the actions taken by top performing centers and just translate them to individual sites? Why do we have to play the game of, I understand, I will say, first of all, that maybe there's a different way of doing something in every part of the country, but in the spirit of standardization, why wouldn't best practices that get 100% rating at one facility just be translated to every other facility? Then we'd all be at 100% without having to play the guessing game, which is time consuming as much as it is intellectually stimulating.
Yeah, if I may, I'm trying to share more of those best practices. So in looking at the 140 VAs for each of the metrics, I'm going to be sharing more of those that reach that 98th to 100th percentile, as you suggested. And there's nothing that precludes us from contacting them individually, or at the VISN level, I'm also recommending they be a part of our future meetings where they could dial in and as we've done in the past with some of our QIDCs, share the best practices and try to learn from them. So absolutely, I think that we do need to incorporate what some of these VHA leaders are doing, because the scores are remarkable. If I may add just one thing very briefly, I did include in some of our recent presentations an attempt to do, as Darlene was saying, shift the discussion just from the NDPP or performance reports to why we're doing this. And the topic that I included was shift the discussion from performance numbers to lives saved and improved. And the one thing that I'm trying to do a lot of research and finding is what would an improvement look like in terms of from the median to the 90th percentile. 2,700 lives could be saved if all smokers were advised to quit at the 90th percentile, according to NCQA. 2,500 lives could be saved if all women were screened for breast cancer at the 90th percentile as compared to the median. We also have things like 28,000 lives could be saved, 50,000 strokes could be prevented if everyone with hypertension received care at the 90th percentile. I think it's disappointing that we don't hear enough of this from VHA. When I've shared much of this information recently at some conferences, I did get a candid response that they're not seeing these kind of numbers nationally. Even things like the diabetic, the retinal exams. 24,000 people lose their sight every year to diabetes, to diabetic retinopathy. And nationally, there's only a 25% screening rate. VA is up to 90% in some cases. So we are doing better. We should celebrate that. But there's real lives to be saved and improved with these numbers. And I don't think that gets enough attention. I'm open to your suggestions about that, because these are the kinds of things that I do believe we should share. So as Darlene was very astutely suggesting, it's not about the performance reports itself.
Darlene, you're on mute.
So Joe, I said that has always been our philosophy. And when we work together, and I respect the comments that you made. And Dr. Ashley, what excellent suggestions. Joe, maybe that is something that, the network could take that approach with those areas from a VISN level that, we are underperforming in the most. There could be those things that are looked at across the board. I think that, though, if instead of waiting for that, I think it's a wonderful suggestion. That may be the areas that we focus in on our behavioral health. Are we, looking at the, top 2, top 3 performers and asking those questions? And it doesn't have to be at the service level. It could be at the, at the level of the team that's working on these things, the approach that we take. What is going on in our specialty care areas where we've dropped? I mean, we've always had great. Is it because of COVID? I don't know, but someone needs to ask these questions, and that would be what would be helpful. Amy had put in the chat box, I think that is where our ICC come into play.
Yeah, I mean, I think that's, the community of practice, where people connect and create an avenue to exchange the information and knowledge and to share the ideas. So I hear a lot of that when I sit on the ICCs, and also we're not trying to reinvent the wheel for some of the, underperforming metrics. Like, for example, we are adopting the best practice of one of our VAs in the VISN. I forget which one, but in regards to the tobacco and ETOH metrics on the inpatient side. So we're not trying to really reinvent the wheel, but to get those ideas and exchange those ideas and utilize them. So we're not, starting from square one.
Yeah. So, I mean, I sit on the primary care, I co-lead that, and I don't know if we ever have presentations. Rachel's on from other VISNs. It's always within our own, and I know that there are some really great facilities that are doing good things, but we have an opportunity to look at the data that Joe gave us, and as Dr. Ashley had pointed out, to look at those that are at 100%, 98%, 93%. and what are they doing? Maybe we can bring that part of it forward. Okay. All right, Joe, I thank you, and I'm hoping that you do get some invitations from others. You know, you're always willing to come on, and you're always willing to help us in Albany, and to know that we very much respect what you're doing and appreciate what you're doing, and thank you again.
Well, and thanks again for the invitation. It was good to hear from everybody today, and I look forward to meeting with everyone again soon.
Thanks, Joe. Maybe it will be face to face soon.
That would be great. Thanks. Bye.
So I think what I'd like to do, we have about 15 minutes left. We're going to defer most of the pieces on here. There's a couple of things that I want to attend to, but I wanted to get a reaction from those who, was the presentation worth it? Did you feel that it added some depth to your thinking? Are there other things that as leaders you want to hear about? Is there assistance that you might need as I'll be meeting with a lot of the points of contacts for the ND's performance plan so that we can talk strategies. What is it that you would like, or what comments might you have?
Darlene, it's Amy. For me, I think it definitely needs to get down to the frontline staff, and maybe even broken down a little bit further, and to the providers as well. I think for me too, there's so many changes that even I need more information on. Like, I wasn't even aware that there was a new change for sepsis, you know, early management bundle. So it's those types of things that I think as the changes come down, we need to know what those are, and, you know, to better understand what the metric means, and how we can, you know, sustain it. I mean, it sounds like we're doing well in it, so I'm glad to hear it, but I just didn't even know that that was even a metric. So maybe QM can kind of break things down a little bit more in terms of the new metrics.
And I know Marlene had it on to go over today rather than having, but I thought it would be a good idea to have Joe there. And then as we're meeting with the POCs, to really break it down for them so that they thoroughly understand it.
Yep.
Yeah, if I could jump in here, I find the composite metrics very confusing, and the way we refer to them, you know, GS 14-90 exclamation point, that is just totally meaningless to anybody who isn't really among the cognoscenti of this kind of thing. And so I think we need to find a way to communicate that stuff down to the people who are actually doing the work and say, yeah, there's this composite measure, but it really amounts to asking the veteran, do you smoke, and can we help you stop smoking?
So I guess sale for dummies type thing. I didn't mean that in a bad way, but put it into.
I'll sign up right now as one of the dummies, you know.
So maybe if anyone's willing to want to do this within their area, you know, we can help you facilitate with Joe coming in and being a part of that, if it would be helpful. I know it's finding the time, but we owe it to our employees so that they understand what the organization is being held to.
I think inviting him to a primary care council would be great if he hasn't been there already. I mean, I know Dr. Grimm and Melissa go through all of those metrics, but it might be a good idea to break it down even further for them.
What about if,
Melissa, you on? Is that something you guys have done?
We have in meetings, we've gone through the metrics, gone through the sale, gone through EQM, EPRP. We have done it with primary care. But yeah, we can invite you to a meeting if that's what you would like.
it's not really what, I would hope it would be what you would like, Melissa.
Yeah,
Right,
no,
feel
I'm
it's
just wondering
necessary.
if the staff know what the definitions of each metric means, the work behind how to make it, you know, how to sustain it or improve it. I'm sure that that's all discussed, but
yeah, and you know, to Dr. Howard's point, it's, you know, we're looking at this measure, not necessarily the number C8XP30, you know, and I just made that up, but you know, we make it so it's manageable and people know what it is that we are looking at overall.
Right.
And we look at the different teams as well.
Sounds like Star Wars when we were talking about those CX-30s. What about the CBOC meetings? Do the CBOC managers, especially the contracted staff, have an understanding of it? Dr. Grimm, do you think?
She's not on, but you know, Rachel
Okay.
does have, Rachel has meetings with the PAC teams as well as the contract model CBOCs. So whatever is disseminated to the, you know, the VA staff is disseminated to them. So there should be no breakdown in communication.
Okay, but Joe might be able to drill down and help with that. The other thing, I think that Dr. Ashley, again, you're really right on today. I think it'd be a critical step for medicine, and section leads are in the dark. They are in the dark, and they think that, you know, as an integrated healthcare system, I think people, you know what they're being measured against, and I think that's what we need to let them know. But to talk about it in terms of the lives saved or the impact on healthcare and where we need to be an organization is important. I don't know how to help to make that happen within medicine. I don't know what specific meetings you have that we could do that in.
Marlene, is Marlene on? I know that. Yeah, I know that, for example, just today, right, they restarted the all-cause readmission work group.
Yeah,
we're
starting it today. Yep.
Yeah, I mean, it is, maybe that's what Dr. Ashley means. Is there somebody from medicine on that team?
Dr. Beebe is.
Yeah, it's just, I guess, including them in all these work groups.
Just for buy-in, it's going to be very important for the individual section leads to be involved with this so that they can in turn explain the situation to the folks who are really in the front lines of providing care, so that there's a connection, because a lot of this stuff seems completely unrelated. You know, it falls into the administrative basket, which is usually the waste basket when
Yep.
people are looking through their emails and sorting them out. Like, this bears no relation to reality. That's the over 30 days consults, the action requireds. These are, and I think because they can be so dismissive because they want to focus on the clinical care, providing the link so that they understand how ultimately, you know, even if you're cynical about it and you say, you know, if you're perpetually underperforming, it broadcasts a message of either disconnection or incompetence or both, and that's not good. You're unlikely to get help under those circumstances. So we want to try to be responsive and organize ourselves in a way that suggests we're making good use of resources to address these issues, instead of ignoring them, which I think is that My experience is that I do a lot of begging and personal outreach, and please do it for me. But you know that's that's not always the best strategy. In a pinch, it has worked, but I think you want people to feel vested in this stuff. Like it does have meaning, it is important. And then what happens, we saw a little bit of that in cardiology, where there was a flip, like, okay, we get it, this stuff needs to be done, and then it becomes part of their routine work processes.
But I think, Dr. Ashley, this is Sam, I think you make excellent points, but I think we also need to rely on our POCs that are at these meetings. So, for example, you just talked about Dr. Beebe being on one of them. If Dr. Beebe is at this meeting as the representative for the area, Dr. Beebe needs to bring that information back to the group about the metric and what it is, because a lot of times scheduling some of these meetings is increasingly difficult with all the providers and the nursing staff to be able to attend them. So that's why we have those kind of representatives, and it's really getting the onus on them to bring the information back too.
Agreed. That's an important mechanism. I think that when some of the sections have less problems than others, I think part of the problem is the sections are oftentimes very different from each other. So you can't talk to them all at once. Particularly, there are broadly non-procedural and procedural sections. The procedural sections have issues that non-proceduralists just don't. It's not relevant at all. So I think, and cardiology and pulmonary and GI are extremely different. Yes, there's some overlap, but they really do have different problems. And so I think at some point, yes, Dr. Beebe is going to be very effective in bringing messages about these metrics home to the hospitalists, and I think she can do that effectively. But if you don't have the section lead in cardiology and the section lead in pulmonary critical care and the section lead in GI involved in working on these things too, and often I find, when they go through the metrics as they did today, it's useful from the 50,000 foot point of view, but sometimes it still leaves you scratching your head at the end of the meeting where you say, well, which of the metrics do I actually are impactful to me? And then what do I need? What message do I need to bring to the individual practitioners and the organization, the structure of the practice, in order to make systematic changes so that these things are addressed? And we do talk about this stuff in the ICCs. We definitely, and it's like a mandated talk. Kirkdale is very animated and engaged on all of these issues. They're definitely important to him. I definitely get that. He wants me talking to leadership here and bringing, there's supposed to be this 360-degree communication, which is very good. But I think sometimes there's something lost where the rubber meets the road. And we also are talking about, like, what's the best practice for our VISN on this metric? We're at 80%, say, and Syracuse is at 86%. Let's go there. Well, I don't really want to talk to Syracuse. I know about Syracuse, they're doing 6 points better. I want to know what they're doing in Michigan, where they're doing 16 points better.
Yep.
And then when I try to contact Michigan, as I'm sure any of you know, who's tried to talk to anybody in a different VISN, it's a crapshoot. Do you get someone who can help you? Do you get through it all? It gets extremely complicated, which is why I am not in VACO, but if I were, I would assemble these 100% performers and say, what is it you drew? Drill down, figure it out. Maybe it's a sham. That's also possible. But once validated, disseminate it widely. We should all be doing it like this.
So maybe we can approach it as, you're making some really valid points. Maybe we can approach it as our quality office can make the contact with the quality office within that visit, within that facility, and to gather that information and then share it back with the areas that need to be. Otherwise people are going to be calling their points of contact at each of their facility, but if we can get this as a package for our organization, that may be helpful. The other thing that I'm reminded of, Dr. Ashley and others, is the surgical summit. I mean, we have a surgical summit every year with national. And for me, I think that it really highlights, you know, the surgery area really knows where their focus is and how they need, where they're performing and how they're performing with their peers across the country. We don't do that a lot with other areas. So I think for the next step, I know that it's 11 and everyone is moving, and I want to get with Marlene, with the other leaders here, and talk about some of the strategies that we identified, so that we are, what are we doing to leverage our strengths? And then we know those 50% of measures that are underperforming or have dropped, or 48%. And what are we doing to ensure that there's teams working on those to make improvements? And then I have gone through all of these measures and focused in on those things that are in the NDPP, and where do we have to meet with those POCs, which I'm meeting with them individually. So I think if we tackle it from a lot of different, I guess, areas, maybe together we can understand it. I would still ask you, if you want to drill down or get this to be communicated with those within your section or your area, you reach out to Joe, or we can help facilitate that. I want to thank you for being a participant. Thank you for the discussion, and this won't be the last one. I know that we're already in to the end of the second quarter almost, but we still have 2 more quarters to go. Again, thank you for all of your effort, and hopefully next time we'll be face to face. Thanks, everyone. We're going to go to the 11 o'clock meeting that most of us have right now, which is our HRO Readmission Collaborative, or our QCR in brief. So we've got 2 meetings to attend, folks. Thank you.